Gianni, a 10-year-old child diagnosed with bipolar disorder, whose first suicidal attempt was at the age of 4, his exact words were, "I hear voices from my stuffed animals. They scare the crap out of me. They are just not friendly."
Last February, an 11-year-old Egyptian child, he committed suicide using his school bag. He is copying that he had seen in a video game.
An 8-year-old child from Jordan committed suicide last year after being bullied at school. These are 8-year-old children we're talking about. They were mocking the congenital malformation in his hand. I am Dr. Abo Eleez, this is Dr. Eleez Ezzat, and this is Dr. Nevian Nabil. We are honored to present you an insight on pediatric suicide, that's suicide in ages under 12 years. Pediatric suicide is not an uncommon problem. It is a recurring tragedy in the news and in the newspapers.
Pediatric suicide myth. It can never occur to my child. Talking with children about suicidal intent might lead to committing suicide. Depression and other mental disorders do not occur in young children. Suicide occurs more in lower socioeconomic groups. Suicide comes out of the blue, with little or no warning symptoms or signs before it happens at all.
Pediatric suicide is surprisingly one of the leading causes of death in below 12 years of age, and the fourth leading cause of death in 12-year-old children. Strangely, the youngest recorded case is 5 years old. In the past, it was believed that children couldn't commit suicide, but in a recent scientific study showed that children as young as preschool can display suicidal behavior and suicidal thinking. Specific data concerning this topic are underestimated and underreported, partially because of mistaken classification of completed suicide attempts as accidents, and because of children are too cognitively immature to display suicidal feelings. Now it's time to talk about who the vulnerable groups are. Recent studies show that the previous suicide attempts is the strongest predictor of future attempts. Moreover, studies show that the children who have previously attempted suicide are up to 6 times more likely to attempt suicide in adolescence.
The overwhelming majority of the cases, 80% of attempts and 90% of completed suicide, have a history of mental illnesses, particularly depressive disorders. Bipolar disorder is especially hazardous as the patient has the will to act on his negative feelings during episodes of mania. And in the genetically predisposed, depression can be precipitated by acute stressors such as changing schools or parental divorce or chronic maltreatment, acts of child abuse, whether commission or omission, physical or psychological. Other psychiatric disorders that may precipitate suicidality include anxiety disorders, conduct disorders, substance abuse, PTSD, that is post-traumatic stress disorder, and ADHD, that's attention deficit hyperactivity disorder. The condition may also be medical, SLE, and endocrinal diseases such as Addison's disease are associated with mental disturbances. Others, such as HIV, are associated with excessive social pressure.
Among our vulnerable groups also are children who are pathologically preoccupied with death. Children who are suicidal tend to think more, dream more about death. They fear and worry death more. This is in contrast to normal preoccupation with death, which is usually temporary and follows a related event, like the death of a family member or the death of a pet. Not surprisingly, negative home and school environment can influence suicidality. Negative home environment in the sense of poverty, divorce, which is a very common risk factor, physical and sexual abuse, witnessing violence between parents, negative school environment like negative peer pressure, poor performance of the child at school, loneliness and continuous bullying at school. In a paper evaluating preschoolers showing suicidal behavior in the age group of 3.5 and 5.5 years, divorce was a common risk factor, however it was not the only one. It was a part of a pathological frame in which children frequently felt they were unwanted by their parents. Children with family history of psychiatric illness or suicide among their parents or their siblings are also among our vulnerable groups.
There are a lot of warning signs can alert us to the child who can commit suicide. For example, sleep or appetite disturbance, personality, mood changes, On the risky behavior, as a child can be violent towards his peers, or discussing death or methods of suicide among his relatives or his family. Also decline in schoolwork or anhedonia, which defines as the child lost interest in his environment. Many wonders what could motivate a child to commit a suicide. For example, in the form of a family problems, like he had a guilty over family problems, especially divorce, or depressed or lost parent, or in the form of personal problems like self-punishment or escaping from punishment or abuse or psychotic symptoms, as he hearing voices instructing them to commit a suicide, or in the form of adaptation problems. Problems coping with grief or copying the act of suicide without understanding the consequences, or he searching for a more comfortable and more happier place. In contrast to adolescents who often commit suicide due to romantic relationships, conflicts with the parents, and disciplinary crises are potential precedents for young children. There are a lot of methods that can child use to commit a suicide. For example, and the commonest one is hanging. And it's more common in young boys, while in older boys they usually using more common to shooting himself with the firearms. In the other hand, in a girls, it's more common to leap herself from heights. And other methods like taking an overdose of medications or leaping in front of traffic.
Prevention of pediatric suicide encompasses multiple levels within the community: home prevention, school prevention, and prevention on the level of the primary health care. First, home prevention. Sporadic declarations of suicidality amidst rage spells are usually benign. It's repetition that must be taken very seriously. Knowledge of the warning signs on all levels is very important. Having prolonged, bold, yet caring conversations with the child about his distress without prejudice and without scrutiny is the first step towards stabilizing the problem. Seek professional help whenever necessary, and mainly the child's pediatrician, but also suicide hotlines. In Egypt, a suicide hotline was available with Befrienders Cairo until recently. It was taken down. Show the child that you care about him enough to spend quality time with him, doing the stuff he loves. Improving family bonds shows the child that love is a core family value. Parenting through emphasizing the positives rather than criticizing the negatives. And on suspicion, continuous monitoring of the child and restricting his access to means through which he can harm himself may become necessary. School prevention. The prolonged relationship between teachers and students, the ability to monitor scholastic performance, and potential sources of distress, such as bullying, make school a ripe environment for prediction of pediatric suicide. Multiple screening tools are available, mainly questionnaires that aim at the detection of the warning signs. Positives are given mental health care, professional mental health care referrals, their parents notified, and are followed up at school with an on-campus professional. However, the cost-benefit ratio of implementing such a system is controversial, with the lack of adequate studies showing the efficacy of such a system.
Now, prevention at the level of the primary health care. If on good terms with the child's pediatrician is the best place to start, considering his prolonged relationship with the child. Screening at the PHC level mainly fishes for depression. Screening during acute care visits, like when the child comes with gastroenteritis, for example, is better than screening during routine follow-up. As the child's psychological instability is likely to be more evident under such stressful conditions. Parents should be carefully warned and educated about the warning symptoms and signs mentioned before. Once the pediatrician suspects that this child is showing suicidal behavior, he should interview the child in the parent's absence. The interview should start with casual questions like, apart from cold, how have you been doing? How's school? How are your friends? How are your parents? These questions do not arouse suspicion, slowly building up on any detected topics of distress ending in a blunt confrontation when needed, up to asking the child, have you ever wished you were dead? Have you ever intentionally hurt yourself? If you were to kill yourself, how will you do it? Follow-up interviews are essential, and hospitalization of extreme cases and cases which cannot be monitored may be needed. Now that the three of us have talked to you today about pediatric suicide and acknowledged the magnitude of this overwhelming problem, our message today, especially for our dear colleagues who will soon be working in primary healthcare centers all over the country, and are supposed to have a close contact with the community and in a position allowing them to offer continuity of care, is to be fully aware that there are suicidal children out there and to be knowledgeable enough and focus on picking up children with early warning symptoms and signs, especially for depression. Always remember, depression is treatable while suicide is only preventable. Thank you.
شكرا يا جماعه على البرزنتيشن الرائعه ده. ايه الموضوع حلو جدا جدا، وفعلا مواضيع الساعه من السايكايتريك ديزيز دي دلوقتي يعني في مصر عندنا للاسف اون ذا رايز، مش بره بس في امريكا واوروبا، لا عندنا اون ذا رايز. ونشكركم على طريقه البرزنتيشن بتاعتكم كلكم والتيم ورك اللي عملتوه واللانجوج الرائعه اللي عملتوا بيها. طبعا جهد المجهول او يعني من وراء الكواليس دكتوره نيفيان نبيل، هي يعني ما شاء الله دايما بتقود المجموعه بتاعتها انها تدي such يعني presentation and this expected from Nevian. Nevian was my own يعني dear resident ولغايه دلوقتي she's very active وبتعمل ما شاء الله حاجات كويسه دايما في البرزنتيشن. حد عنده اي استفسار اي تعليق دكتوره منى؟
لازم لما الحاله اللي سالنا فيها لازم تكون حاله صعبه جدا وانا بحمل المسؤوليه جدا، بخاف منها عشان هي شاطره قوي 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 ما شاء الله.
شكرا يا محمد ومحمد اشرف ومحمد عزت شكرا.